Hi, I am Dr. Sunjith Sudhakar from the Department of Oral and Maxillofacial Pathology, PMS College of Dental Science and Research. Today we will be discussing on the topic developmental disturbances of the oral cavity, specifically the tongue. So the major developmental disturbances affecting the tongue are aglossia, microglossia, macroglossia, ankylosglossia, cleft tongue, fissured tongue, hairy tongue, median rhomboid glossitis, benign migratory glossitis, also known as geographic tongue, lingual varices and lingual thyroid nodule. So learning objectives of this topic would be the student should be able to enumerate the developmental disturbances affecting tongue, and the student should also be able to describe the etiology, the epidemiology, clinical features and management of each of the developmental disturbances affecting tongue. So aglossia, also known as absence of tongue, which is a rare condition. Only less than 35 cases has been reported till date in scientific research. The anomaly is associated with malformation of extremities like hand, feet, along with cleft palate. Microglossia. Microglossia means small tongue. Lack of muscular stimulus between the alveolar arches cause mandible growth restriction, producing lack of space for tongue development, causing the tongue to be smaller than normal, and the lesion is known as microglossia. Macroglossia or large tongue. Macroglossia is also known as tongue hypertrophy. So the tongue will be larger than usual. Etiology include dilatation of lymphatics, muscle hypertrophy, inflammation, amyloidosis or Down syndrome. Classification of macroglossia. Macroglossia can be broadly classified into true macroglossia and pseudo macroglossia. The lesions again can be subdivided based on etiology into congenital and acquired. True macroglossia. Congenital or by birth, caused by idiopathic muscle hypertrophy, hemangioma, lymphangioma, Down syndrome and lingual thyroid. Acquired causes for macroglossia include hyperthyroidism, typhoid, tuberculosis, hypertrophy, carcinoma and amyloidosis. Pseudomacroglossia. Pseudomacroglossia includes any of the conditions which force the tongue to sit in an abnormal position, such as habitual positioning of the tongue, enlarged tonsil or adenoids displacing the tongue, low palatal vault and decreased oral cavity volume displacing the tongue, smaller maxillary or mandibular arches displacing the tongue, severe mandibular deficiency or retrographic mandible, or neoplasms or cancers of the oral cavity causing displacement of the tongue anteriorly. Other causes of pseudomicroglossia include vitamin deficiencies, angular stomatitis, edema of the lower extremities and hypothyroidism. So the student should be able to enumerate the etiology or classification of macroglossia. Ankylosglossia, also known as tongue tie. Ankylosglossia occurs when lingual frenum attached to the bottom of the tongue anteriorly and restricts free movement of the tongue. Ankylosglossia can cause feeding problem to infants and speech difficulty in young children. Treatment include surgical correction of the anteriorly placed frenum known as frenulectomy or frenectomy. Cleft tongue. Cleft tongue can either be a complete cleft tongue, also known as the bifid tongue, or a partial cleft tongue. Complete cleft tongue occurs due to lack of merging of the lateral lingual swellings, causing complete cleft tongue. It is also known as bifid tongue. Partial cleft tongue. Incomplete merging and failure of the groove obliterating by underlying mesenchymal proliferation causes partial cleft tongue, which is more common than complete cleft tongue. Moving on to fissured tongue. Fissured tongue is also known as scrotal tongue or lingua plicata. Fissured tongue is characterized by grooves that vary in depth, which is noted along the dorsal and lateral aspect of the tongue. Fissured tongue is also seen in Merkelsen-Rosenthal syndrome and Down syndrome. It is a non-symptomatic condition and which is considered as variation of the normal tongue architecture. Treatment is not required for fissured tongue. Merkelsen-Rosenthal syndrome. Merkelsen-Rosenthal syndrome is a rare condition consisting of a triad of persistent or recurring lip or facial swelling, intermittent seventh or the facial nerve paralysis, or also commonly known as Bell's palsy, and concomitant fissured tongue. Treatment include intralesional steroid injections. Median rhomboid glossitis. Median rhomboid glossitis causes the posterior dorsal point of the lingual process occasionally defective, leaving a rhomboid-shaped, smooth, erythematous mucosa, which is lacking in papilla or the taste buds. Earlier, it was thought to be a developmental defect, but now it is considered to be due to Candida infection. Other names of median rhomboid glossitis include central papillary atrophy or posterior lingual papillary atrophy. The newer name based on etiology is posterior midline atrophy candidiasis. The lesion is very rarely seen in newborns or children, but commonly seen in male adults of middle age. Infected cases show midline soft palate erythema in the area of contact with the underlying tongue lesion. It is referred to as kissing lesion. Treatment include antifungal therapy. A topical application will reduce clinical erythema and inflammation due to Candida infection. Geographic tongue. Benign migratory glossitis, otherwise commonly known as geographic tongue, is characterized by changing pattern of serpentinous white lines with surrounding areas of smooth depapillated mucosa. Depapillated area resemble continental outlines of a globe, giving the characteristic name geographic tongue. The lesion is also known as wandering lash of tongue. Treatment include steroid and local antifungal therapy. Hairy tongue. Hairy tongue, otherwise called lingua nigra or black hairy tongue, is characterized by hypertrophy of filiform papilla on the dorsal surface of the tongue. The condition often occurs in individuals with poor oral hygiene, lack of toothbrushing, eating a soft diet with no fibers, and bedridden patients due to chronic diseases. Contributory factors for hairy tongue include tobacco use, either smoking or chewing tobacco. Excessive coffee and tea consumption is also considered to be a factor causing hairy tongue. The factors account for the various colors associated with the lesion, such as brown, white, green, pink or black color seen on the dorsal aspect of the tongue. Causes include increase in keratin production or a decrease in keratin desquamation. Hairy tongue is found in about 0.5% of adults. Although the cause is uncertain, most people affected are heavy smokers. Other associated factors causing the disease is antibiotic therapy, poor oral hygiene, general debilitation, radiation therapy, or overgrowth of fungal or bacterial organism. Normal filiform papilla are approximately 1 mm in length in normal individuals, whereas in hairy tongue it will be more than 15 millimeters in length. Hairy tongue has been reported with more frequency in male patients with human immunodeficiency, commonly called HIV, as well as intravenous drug abusers. The disease is usually asymptomatic, but Candida infection causes glossopyrosis or burning tongue syndrome. Treatment include a simple use of tongue scraper to remove elongated filiform fibers and retard growth of additional growth to heavy growers needing surgical removal of the papilla by using electrodesiccation or laser therapy. And the patients are always advised to stop smoking habit. Lingual varices. Lingual varices. A varix is a dilated tortuous vein, most commonly a vein which is subject to increased hydrostatic pressure but poorly supported surrounding tissue. Varices appear as red or purple short-like clusters of vessels on the ventral surface and lateral borders of the tongue, as well as floor of the mouth. Person over 60 years of age has more sublingual varices. Thrombosis is common and care should be taken during oral surgical procedures. No specific treatment is indicated for management of lingual varices. Lingual thyroid nodule. A lingual thyroid nodule is a developmental disease characterized by development of submucosal mass of thyroid tissue on the mid-posterior dorsum of the tongue. Etiology include complete or incomplete failure of the thyroid to migrate. So the lingual thyroid is an anomalous condition in which follicles of thyroid tissue are found in the substance of the tongue, and possibly arising from thyroid anellage that failed to migrate to its predestined position from its remnants that became detached and were left behind. Physical examination include thyroid gland assessment in patients and scanning with radioactive iodine. Management of the lingual thyroid nodule includes surgical removal of the nodule if the thyroid is present in the normal anatomical position, and if thyroid is absent, the lingual thyroid should be preserved. So a frequently asked question from this chapter is eglossia, microglossia, macroglossia, ankylosglossia, cleft tongue, fissured tongue, hairy tongue, median rhomboid glossitis, benign migratory glossitis, otherwise called geographic tongue, lingual varice, and lingual thyroid nodule. So any one of them can be asked as short note or short essay, and a commonly asked question is developmental disorders affecting tongue. So that brings to the end of the topic, developmental disturbances of the tongue. Thank you.